Srinivas Rajkumar, who is with the All India Institute of Medical Sciences in New Delhi. Dr. Rajkumar, thank you for being on the program. So I was talking about, there's so many interesting questions and also vexing questions, frankly. In terms of genetics, I'm assuming as a layperson that there's not much difference between the population in Pakistan and in India and also perhaps in Bangladesh. But give me a sense of why is it that Bangladesh and Pakistan are witnessing a flattening of the curve, whereas India's curve is rising. Now, before you joined me, Dr. Khan was talking about smart lockdowns and all that, but my sense is that that's exactly what the Indian central and state governments also did.
The very scale of India, having the second largest population in the world and having a vast expanse of land from north to south, east to west, makes it more prone to have a prolonged pandemic. So India is supposed to have peaks in different parts of the country, in different cities at different times, and the flattening will be slow to happen. So some cities like Delhi have already flattened the curve. Chennai is has almost flattened. But considering, for example, to make sense of the magnitude, the population of Pakistan is just 2 times of Maharashtra. So considering the vast magnitude of the country, and we had a very prolonged lockdown, which delayed the onset of the pandemic. So obviously it will be late to fall, but other measures are well in place, and there is also increased focus on home-based care, having COVID care centers. So there is good focus, and some states which are not able to handle are imposing lockdowns on a need-by-need basis. So the key is to open up, have lockdowns when the health facilities are not able to cope up, and learn how to manage on the go.
No, I perfectly understand that you're making in terms of the size of the population and the diversity. I understand that. As a matter of fact, you talked about Pakistan's population twice the size of Maharashtra. UP is a better example, perhaps, because UP's population is a little less than that of Pakistan. But here's another question. I was talking to Dr. Khan also, and earlier to Professor Emily Smith. What do we know about how and why the virus impacts different people differently? We know about comorbidities and the rest of it, but there are lots of cases of young people who have been, laid waste by this virus, whereas the older people who were either asymptomatic or just had, minor symptoms and pulled through.
Everybody is vulnerable, but some population are more vulnerable than others. And we know that in the initial part of the pandemic, countries which had to face the brunt initially had a higher mortality rate. But with the learning that came from the treatment, particularly use of steroids and access to ICU facilities, access to simple oxygen, which has improved over time, has let countries which were late to have the infection manage the pandemic well. So that is what we can make sense of from the current performance of even countries with very poor human development index able to manage the pandemic well. For example, as you say, Pakistan, then again India, some cities of India, then again Bangladesh, or be it other countries which are able to manage well with very limited resources, just shows that the experience we have been able to accumulate, analyze, and propagate by the access to modern means of communication has helped us manage the pandemic better.
Okay, stay with me, Dr. Kumar. Let me go back to Dr. Khan here. Dr. Khan, since there is no vaccine, give us a sense of what are the standard ways of treating a COVID-19 patient, especially someone who's showing symptoms and who's likely to get hospitalized and perhaps, essentially, in terms of going on to the ventilators and oxygen and the rest of it. So what is it that you're doing in the absence of a vaccine?
Well, as mentioned earlier on by the other guest, over 6 months we have learned a lot, and the mortality generally has now much lower than it used to be at the beginning of the pandemic. we did learn from several studies. We did learn when to intervene and what the red flag signs, what can be called at. So I think there are still good number of patients, 30–40%, who do not have any symptoms at all. We still continue to see those patients. Just incidentally, you find them out in testing and in isolated at that period. And then there are people who do have just involuntary symptoms. But what we did learn from autopsy studies and how this virus is behaving, what it's causing in the body. And there was one interesting term coined, which is called happy hypoxia. That means when somebody's oxygen drops, normally somebody's oxygen drops, so they become symptomatic. They have symptoms, they are short of breath, they have a difficulty in breathing. But in this COVID, what was happening, the patient does not know at all that his oxygen had dropped to the critical level. So he never had any symptoms. It was called happy hypoxia. So the thing which we learned that earlier you identify those patients, the better the outcome would be. How you identify the markers, the inflammation, what is called the hyperimmune response, which we did know now, which happens in those patients, even the time frame that it happens after 1 week of your sickness symptoms, and then 5 to 9 days are very critical. So I think the medical community learned that these are the specific, the period time frame in the course of the illness where you need to intervene. You need to be very observant. And also, you may have seen in our country, the people have bought people's oximetry and keeping at home. So there was a lot of campaign, a lot of education, and for the public, for the patients, and for the healthcare professionals, which helped collectively in getting to this stage. We know the vaccine is not around the corner, and it may not be for a foreseeable future, but still the emphasis is on prevention, cutting down the transmission, and identifying those patients who are at risk of getting a severe disease. Another thing happened that very early on, the management, for example, the people who are on the ventilator, we learned in this pandemic, they are behaving differently than the other influenza pandemic, which we have seen earlier on. So the strategy was changed. It changed towards giving more oxygen, for example, and using high flow oxygen or using non-invasive ventilation than invasive ventilation. So I think over a period of time, the world learned from each other's experience. And
that's very interesting. That's interesting. I am also running out of time, so quickly back to Dr. Rajkumar, and a quick response, Dr. Rajkumar. What Dr. Khan is saying is that also the learning trajectory you've seen in India? Is it more or less the same, or are there any other observations?
Now we are learning as a world rather than as countries individually. There is more collaboration than ever, possible through global agencies like the World Health Organization, which we are participants, and we are learning from the experience, and it has been successfully implemented. As Dr. Khan summarized well, that we have provided pulse oximeters for home-based care, and regarding the happy hypoxia and other aspects of the illness, widespread use of sanitizers, hand washing, masks. So the experience has been almost the same, but considering the geographical differences, we will have a prolonged pandemic, but we will recover, and finally the results would be
okay, great. Thank you so much. That was Dr. Srinivas Kumar. Thank you to Dr. Ejaz Haider. This is all from In Focus tonight. We shall see you tomorrow at the same time. Keep following our latest updates on social media at indus.news. Good night and goodbye.